So this will be a quick flyby overview for pediatric brain tumors. To cover it in 20 minutes is actually kind of a tall order. So we're going to cut to the chase and really exclude a couple of tumors like low-grade glioma as we move forward. And then we'll just give brief epidemiology. We won't talk about clinical presentation. And then at the end, I'll turn it over to Dr. Dave Ebb, to discuss high-grade gliomas, as that, I think, has the greatest room for improvement in some of the tumors that we're talking about. So basically, pediatric brain tumors are the second most common malignancy, and if you count benign brain tumors, they're actually the number one common tumor. There's about 250 cases per year, and it is the most common solid tumor of childhood. There's about, in contrast, there's about 33,000 new cases in the adults per year. The majority are gliomas and meningiomas in the adults, whereas 50% are gliomas in the pediatric population. And the majority of those are low-grade gliomas, but a significant minority are high-grade gliomas, and there's definite room for improvement with our treatments there. So this is the breakdown. Medulloblastoma is also one of the most common malignant ones, and sort of a lead example of where we're going with biology. And so I'll start off with medulloblastoma.
Can you speak up just a little bit?
Sure, I can move this closer. Is that better?
Try that lapel too. Your other lapel.
The other lapel.
Put it in the center.
In the center.
Do whatever you want. Next thing you know, he's just going to put it on the top here.
How about that? Is that better?
I think that's a good.
That's better? Okay, good. So medulloblastoma, this is the most common malignant brain tumor of childhood. It occurs only in the posterior fossa and in very young children, most commonly in the first decade of life. Median age of diagnosis is 7 years. There's a male predominance, and there's about 450 patients per year. Sorry about that, I was looking on the next slide. 450 patients per year. It is a tumor that seeds the cerebral spinal fluid, and so when we treat, we have to take that into account. And it presents with seeding or dissemination in about 20 to 30% of patients. There's three major histologic subtypes. It's really the classic, the desmoplastic, and then the anaplastic. And the anaplastic large cell variant is kind of a bad actor. So we break down the prognostic groups into three. We have basically two prognostic groups at this point in time: standard risk and high risk, and it's based on whether the disease is localized or disseminated, the extent of resection, and then the histology. So standard risk patients are those that have non-metastatic disease and basically a gross total resection or minimal residual disease. Infant medulloblastoma is a different beast that I'm not going to talk about right now. So it's generally kids older than the age of 3 or older. So we treat them with surgery, maximal safe resection, followed by radiotherapy, which includes whole brain and whole spine, and then to what we call a standard dose, which is 23.4 gray, and then boost to the tumor bed to a higher dose of 54 gray. Then we give adjuvant chemotherapy, which lasts almost a year in this standard risk population. We cure about 80% of these kids. In the high-risk patients that have disseminated disease or significant residual disease, and in some cases, anaplasia, so definitely if you have two risk factors. Anaplasia in the setting of otherwise standard risk disease is really an intermediate risk, but they often get lumped in with the high-risk patients. We treat these patients with high-dose craniospinal radiation, 36 gray to the brain and spine, and then followed by a boost. In addition, they also get significant dose-intensive chemotherapy, not high-dose chemotherapy, but dose-intensive. Now, our treatments come at a cost. The surgery can come with significant morbidities in 20 to 40% of our patient population. Radiation causes delayed development or stunted development in the pediatric population, and so that's age-related. And then the chemotherapy also correlates with hearing loss. Radiation does a whole host of other things too with regards to the endocrine outcomes and second malignancy risks. So we have room for improvement with what we can do with our standard therapies right now. It's effective in many cases, but it comes at a high cost. So at MGH, our claim to fame is really the proton radiotherapy, and we've really pioneered it. And the benefit of proton radiotherapy is that you can really place the radiation dose where you want it to be. And because the brain is developing in pediatric patients, this is really a big advantage. And so you end up sparing, compared to photon or intensity modulated radiotherapy, more parts of the brain, which has benefit in late effects for the pediatric population. And when you're treating craniospinal radiation, when you can spare the anterior structures in the spine part, the heart, the lungs, the bowel, then all of those organs are no longer at risk from the radiation side effects. Now, just an aside to give you an idea, we treat about 120 patients with protons per year. 75 of them are brain tumor patients. We have a very strong referral base, but they come from all over the country and in some cases internationally. And we have a strong record of clinical research, but we don't have a big biorepository of tissue ourselves, although we always review the path on all of our patients. But that's just to give you an idea of what's going on. We are also the PI, or the site. We run a Pediatric Proton Consortium registry, and right now there are 7 centers participating with 3 more coming online. So we have a lot of access to a lot of patients with regards to clinical data. Now, infant medullo is a different beast, and I won't really discuss that right now. But what we've learned over the past is that we are effective in curing between 60 and 80% of the pediatric patients, but those that we don't cure are very hard to salvage. And there's certain biological insights that we've gained recently. And we are starting to move some of these targeted therapies into treatment, but there's still room for improvement. But what we're finding is that these are biologically diverse diseases, despite the fact they look very similar under the microscope. So currently, we're breaking medulloblastoma into 4 subgroups: the Wnt subgroup, sonic hedgehog subgroup, and group 3 and group 4, for lack of better names. Thank you. And basically, they come with different prognostic indications. And this is sort of a busy slide, but it gives you an idea. The Wnt pathway group does the best, and then the sonic hedgehog group is sort of average. Group 3 does the worst. Group 4 is kind of a mixed bag. And these are some of the mutations that go along with the different groups. This is just to give you an idea of the prognostic indicators for each group. And then treatment is really starting to change, but it's just starting to change. And this is the disease that we're the farthest along with in the pediatric setting. So for the Wnt pathway group, we're typically now starting to withdraw some of our therapies and be less intensive. With the sonic hedgehog group, there's now sonic hedgehog inhibitors that we are now incorporating into first-line therapy. We are currently using them in the recurrent setting. And then group 3 and group 4 have really eluded us with regards to targeted therapies. There's some indication that pemetrexed and gemcitabine have some utility, and so there's a current protocol looking at that. Now, I think another worthwhile and relatively common tumor in the pediatric population is the ependymomas. And this occurs in about 5 to 10% of pediatric patients. They can arise 2/3 of the time in the posterior fossa and 1/3 of the time in the supratentorial space. And these typically are locally invasive, and our pathologists will tell us technically they're glial tumors, but they behave a little differently than the low-grade gliomas and the high-grade gliomas that we see. And they typically are a little less invasive, although occasionally we do see quite an infiltrative nature. Now, we are learning a lot more about the subgroups, and there's fewer mutations in the ependymoma population than there are in the medulloblastoma population. Most of the genetic aberrations are epigenetic. And this gives you an idea of what's going on. Typically, what we see are the posterior fossa tumors. They're broken down into ependymoma group A and ependymoma group B. Group A does a lot better than group B. And the supratentorial tumors, the RELA group does a lot worse. I didn't label it, but this gives you an idea. The RELA group does a lot worse. And the infratentorial tumors, it's the type A, does a lot worse, and those are the younger patients as well. So this is more of the outcomes. Now, with regards to treatment, where we are now, the mainstay of treatment is surgical resection followed by radiotherapy. We do not yet have any targeted therapy for these patients. Extent of resection is important. Basically, if you get a gross total resection, your long-term control is double that of when you have a subtotal resection. So the surgeons are under a lot of pressure to do what they can surgically. Chemotherapy is a rather blunt instrument, and its role is being defined at this stage. There's currently a children's oncology group trial where they randomize patients to chemotherapy versus no chemotherapy. But what we do know in the previous studies is that radiation and surgery, at least for the posterior fossa tumors, are critical. The one role that chemotherapy is pretty established is when you have a subtotal resection, you can give 2 cycles of chemotherapy, and the surgeon can often achieve a gross total resection after that. Maybe often is a little too generous, but certainly there's a chance for a re-op. I won't talk about low-grade gliomas. I'll briefly discuss craniopharyngiomas, which is a tumor that occurs in the suprasellar space. It's adamantinomatous in the pediatric population all of the time. It's at least 200 to 250 patients per year in the US. And 70% of these tumors have a beta-catenin mutation. There's a papillary histology that occurs solely in the adults, and that has a BRAF mutation. We have BRAF inhibitors. Unfortunately, we don't get to use them in the pediatric population. So treatment is surgery and radiation are the mainstay. If you get a gross total resection, you don't need to come in with radiation, but that can be very difficult. These are very sticky tumors that are adherent to the optic chiasm and adherent to the hypothalamus and can cause some serious damage when the surgeon pulls on the hypothalamus to take it out. So there's a movement, depending on the look of the craniopharyngioma, to go to more conservative surgery followed by definitive radiation. We are able to control the disease about 80% of the time, but in the patients that have recurrent disease, it's a big problem. Again, we rely on the surgeons, but then the surgeon has to work in a field that's been irradiated, which can also be very difficult. So we use systemic interferon, which has some benefits, and we've also used intercystic interferon. But we could definitely use some better therapies for the patients that have recurrence. At this point in time, I'd like to turn it over to Dr. Ebb.
So pediatric high-grade gliomas are, as Torunn mentioned, a tumor that we see much less frequently in the pediatric population than in the adult population, thankfully so, because both in children and adults, this is a diagnosis that confers a very poor prognosis, regardless of all the various therapeutic interventions that have been attempted over the past 3-4 decades. These tumors have been stubbornly resistant to whatever interventions we can offer. They make up only about 10 to 15% of the tumors we see in children, which is in contrast to the adult population where they occur at a rate of frequency of about 30 to 40%. And they are, for the most part, tumors that arise in the cerebral hemispheres, although a significant proportion can also arise in deep structures, in the diencephalic tissues, and also in the brainstem, where they have a particularly bad prognosis. These tumors include grade 3 high-grade gliomas, the anaplastic astrocytomas, and glioblastomas, grade 4, and they typically present in children at about 10 years of age. A substantial proportion of these tumors will disseminate at some point in their clinical course of these children. The outcome, unfortunately, as I said, is very poor for all children with high-grade gliomas, much as is the case in the adult population. Median progression-free survival is only 1 to 2 years. There are very few survivors beyond 3 years of age. Prognostic factors for children with these very aggressive malignancies include the extent of resection. Since these are highly infiltrative tumors, it's rarely possible for the surgeons to safely achieve a gross total resection, which does confer a somewhat improved outcome. Grade and histology are certainly important. Location, which has a bearing on resectability of the tumor, clearly is an important predictor of outcome. And then there are driver mutations, the list of which is now expanding, that include P53, a tumor suppressor gene, PTEN, another tumor suppressor gene, platelet-derived growth factor receptor, epidermal growth factor receptor, which has played a significant role in the development of treatment strategies in the adult population, where it is overexpressed in a larger percentage of adults. IDH1, a mutation which is seen almost exclusively in the adult population, and when found in a high-grade glioma confers a better prognosis. Unfortunately, it is a mutation that we rarely see in children with high-grade gliomas. And more recently, and very importantly, mutations in histone and chromatin remodeling genes has proven to be a very important identifier of unique biology that we see in children compared to the adult population, and probably a very important driver of tumorigenesis in children with high-grade gliomas. This is just a slide looking at the impact of histology on outcome. At the top are the very low-grade pilocytic astrocytomas. A substantial proportion of the gliomas we see in children, thankfully, are low-grade. The second line down is the grade 2 or fibrillary infiltrative low-grade gliomas. And the treatment for those diseases is very different from what we employ in high-grade gliomas. In the low-grade gliomas, which you'll hear about some, I think, a little bit later, we actually have an opportunity to pause, achieve a maximal safe resection, and observe children with these tumors and wait for evidence of radiographic progression or clinical changes, functional changes that indicate the tumor is progressing, even if the imaging studies don't demonstrate an imaging correlate of a progressive process. And in those children, we know it is actually safe to wait in most cases to intervene therapeutically without compromising the prospects for long-term survival, which are typically very good, in stark contrast to high-grade gliomas, where there is an urgent need for therapy to arrest tumor progression, and immediately after whatever surgery can safely be achieved, radiotherapy is applied, typically in combination with cytotoxic therapies or targeted therapies, all of which thus far have been frustratingly ineffective in preventing subsequent progression of these higher grade gliomas. And I think there'll be some more discussion later today about some of the unique biological features of the low-grade gliomas that lend themselves to therapeutic interventions that are not cytotoxic, that are actually targeted, and actually are very exciting in terms of their potential to achieve durable control of the disease without the toxicities we see with the more conventional cytotoxic therapies we use in more aggressive tumors. Some of the molecular markers of high-grade gliomas that we see, the adverse prognostic findings are p53 overexpression. Again, this is a tumor suppressor gene. You'd think that you have too much of a tumor suppressor gene, that might be a good thing, but typically if we see p53 overexpression on immunohistochemistry, it's an indication that the gene is not functioning properly and not performing its role of suppressing uncontrolled cell growth. p10 mutation is very common deletion in adults, much less commonly seen in children. MGMT is a DNA repair gene. If it is overexpressed, it actually defeats the potential added therapeutic benefits seen with drugs like temozolomide, which is widely employed in the treatment of high-grade gliomas. MGMT overexpression is seen, unfortunately, more commonly in pediatric tumors than in the adult population. I think, as Torunn mentioned, there are enormous numbers of adult high-grade gliomas that lend themselves to clinical trials that can be completed in a much more rapid way than in the pediatric population, where our numbers are, again, thankfully small. And we have borrowed extensively from the adult experience in trying to develop clinical programs for treating children with high-grade gliomas. And they have been largely ineffective, in part because the therapies that we have currently available, both in the adult and pediatric populations, have not been successful in abrogating the pathways that are dysregulated in high-grade gliomas, and in part because the pathways are often different in adults and children with high-grade gliomas. And so this is just an older slide demonstrating that platelet-derived growth factor receptor is actually much more highly expressed in children than in the adult population on the left in the top panels, versus epidermal growth factor receptor, a frequent target for receptor tyrosine kinase antagonists in the adult population, highly overexpressed in the adult high-grade gliomas, less so in pediatric tumors with similar high-grade histology. So as I mentioned, there have been some recent discoveries, very exciting discoveries, that have identified histone genes, H3.1 and H3.3, as very important drivers of the development of high-grade gliomas in the pediatric population. These mutations are actually infrequently seen in adults with high-grade gliomas, and they identify a biologically distinct group of tumors that we see in children. That said, children with certain subtypes, certain histone gene mutations do very badly, much as the adults do, even if they do not demonstrate these histone gene mutations. Children with H3 K27M mutations have a particularly poor prognosis. This is just a table looking at some of the more recently identified biological markers of tumor behavior with existing therapies, all of which have been disappointing. On the far left, you see the impact of the H3.3 K27M histone gene mutation. Those children have a very poor prognosis. You see the survival curve in that lower survival curve panel dropping off very precipitously. And these are children typically who have tumors in midline structures, diencephalic portion of the brain, brainstem lesions as well. They have an abysmal prognosis if they demonstrate a mutation in a histone gene. There is another commonly seen histone gene mutation seen in kids, the H3.3 G34R, and that confers a somewhat less dismal prognosis, and you see that's sort of an intermediate outcome there. And tumors with that particular histone gene mutation are typically found in the cerebral hemispheres. Lastly, I'll mention BRAF V600E, a gene, a point mutation in a gene that has been of great interest in low-grade gliomas, where it is seen with somewhat more frequency. More on that, I think, this afternoon. This is a point mutation that is rarely seen in pediatric high-grade gliomas, but it does offer an opportunity to use targeted therapies, which anecdotally have shown some promise. As I said, this is an infrequent occurrence in pediatric high-grade gliomas, but those children who have tumors with this mutation have a much better prognosis, in very striking contrast to the kids with those histone 3.3 mutations who do very poorly. I think we'll have to skip age on prognosis other than to mention very quickly that there's a fascinating finding that babies with high-grade gliomas seem to have a much better prognosis than older children. The question has always been why. Clearly, they are a biologically distinct group of tumors. This may be related to differences in P53 mutations, which are much less frequently seen in kids less than 3 years of age. It may also be related to the relatively high percentage of very young patients with high-grade gliomas having neurotrophin receptor kinase fusion mutations present in about 40% of these tumors. So there are infants with high-grade gliomas who can be cured with surgery and chemotherapy only. Very different from the picture we see in older children and adults, where the inclusion of radiotherapy is absolutely necessary, and even with its inclusion, survival is typically very short. Treatment, and I will wind up very quickly. This is the classic paradigm, maximal surgical resection on the left, immunohistochemistry to demonstrate findings that support the diagnosis of a high-grade glioma, followed by focal radiation, typically with a good margin to accommodate the infiltrative pattern of growth of these tumors, and often in combination with chemotherapy during and after the radiation. Again, a paradigm that has been largely unsuccessful and very disappointing, despite 3 decades of trying to revise the use of cytotoxic agents that we combine with surgery and radiation. So treatment, again, surgery, maximal achievable resection. Rare that a surgeon can achieve a gross total resection because of the location of the tumor, because of its infiltrative character. Radiation to very high doses, a problem in very young kids, but we're talking about focal radiotherapy in contrast to medulloblastoma, where we are really typically looking at using craniospinal radiation, so whole brain, which is something that we would not deliver to an infant whose brain is very vulnerable to the injurious effects of radiation. And that's followed, that's actually, the radiation is typically delivered with some form of chemotherapy, followed by additional chemotherapy at the conclusion of radiation. A recent Children's Oncology Group study looking at 3 different combinations of cytotoxic drugs during radiation in the hope that we could pick a winner, the best, the most effective combination with radiation that would serve as a platform for later studies. Unfortunately, didn't demonstrate any relative benefit or any superiority among the 3 different combinations. A disappointment, but one that was not totally unanticipated, and perhaps the greatest value of that study is that it mandated tissue collection in all of those cases, which gave us an opportunity, an essential opportunity, to better characterize the biology of these tumors that have been so refractory to the therapies we currently have available, and is the reason why we have to gather here today to think about new ways of approaching these tumors which have been resistant to standard approaches. This is a graph just showing the very disappointing historical experience treating high-grade gliomas. You can see that this is a survival curve with a very precipitous decline in survival within a very short time of diagnosis. That has not changed over multiple generations of clinical trials. More recently, there was a study looking at combining radiation with temozolomide and CCNU, a very old drug, a nitrosourea that has been used going back now probably 3 decades. And the inclusion of CCNU with temozolomide and radiation in this relatively small study, it was 108 patients, again, small numbers of patients in the pediatric population, seemed to demonstrate some marginal improvement over the historical experience. But I think all of us would be very hard-pressed to jump up and down and be really excited by the relative improvement we see there. Yes, it's better than what we have seen historically, but it's certainly far from good enough. Brainstem glioma, I don't think we have time to spend a lot of time on this, other than to say it is a tumor with an abysmal prognosis, and efforts to combine radiation with any of a variety of different cytotoxic agents or targeted therapies have been very disappointing and failed to improve outcomes. And what we have recognized more recently is that, like high-grade gliomas in other locations, diffuse intrinsic pontine gliomas, brainstem gliomas, are not a single entity. They are a very heterogeneous population of tumors that can probably be divided into 3 different subsets based on specific biological features, whether they're genetic or epigenetic features, that may guide us to offer therapies that are more specifically and appropriately targeted, which may lead to some improvement in the historically dismal outcome in children with those tumors. So I will conclude with this. Clearly, we need to change the paradigm that we have employed for treating children with high-grade gliomas. The blunt instruments, surgery, focal radiotherapy, now delivered with greater precision, to be sure, with protons when appropriate, combined with cytotoxic chemo or even targeted chemo, has been very unsuccessful. And in the middle there is a panel that comes from a recent publication reflecting a very extensive review of tumors from both the US and from Europe, where methylation profiling was used. And you can see that the tumors in high-grade gliomas can be broken down into multiple different subsets. They are biologically different, and they suggest that the therapies we apply to children with these tumors should be appropriately tailored to the genetic and epigenetic changes that are unique to tumors in certain parts of the brain in children of certain ages, and tumors that may look histologically very similar but are biologically distinct. So I think the challenges here are tumors can't be taken out if they're high-grade infiltrative gliomas. We have been using a lot of adult experience of necessity for lack of adequate biology until very recently in the pediatric population to guide us. And it turns out that some of the adult biology is perhaps not relevant or even appropriate as a guide for the development of clinical trials in children. There has been a tremendous acceleration in the identification of tumor drivers, both genetic and epigenetic, in the pediatric population over the last 5 years. And it's our hope, certainly my hope as a clinician and the hope of everyone who's gathered here today, that we can utilize those in a way that will more successfully offer an opportunity for these kids to survive these diseases, to live a full life, and to survive them without functional impairments that are often a part of the therapies that are currently available, which can be enormously toxic, particularly to very young kids. I think the overarching comment I have to make here about pediatric brain tumors in general is that we are recognizing that these are enormously heterogeneous diseases, that looking at them simply as tumors that are metastatic or localized, tumors that are histologically aggressive or non-aggressive is not sufficient, and that we need to inform our design of our clinical trials, our protocols, based on the very rapidly evolving understanding of the biological underpinnings of these diseases, and target our therapies in a way that will more likely give these kids a chance to survive and permit us perhaps to de-escalate some of the therapies that are incredibly toxic and are not required for subsets of children who have more favorable biology. And I think with that I need to stop, and thank you for your time.